Well, greetings, everyone, and welcome to the EKG case for the week of June 24th, 2013. This week's case is a really important EKG case, and a lot of you have asked for a little bit more discussion about the case part, and not that we're going to focus less on the EKG part, but this is definitely more case, but it's a really important one. And what is going to prompt our discussion today is an EKG that was sent by Dr. Jason Mansour, who works at Broward General Medical Center in Fort Lauderdale. He actually sent this case to me back in 2010, and I recently had a chance to meet him. I went down there for a visit and a lecture, and Jason is an emergency medicine physician, a great teacher. He does a lot of the teaching, probably the bulk of the teaching in the emergency department. He leads the emergency medicine rotation down there for the medical students and also some residents that work down there, and does a lot of EKG teaching on his own. So I'm going to present a case that he sent me. This was a 47-year-old guy who had presented to the emergency department complaining of some concerning chest pain. Details of which I'm not really sure. We'll just say it's concerning chest pain, and we'll trust him on that. And what complicated things was that this guy had a negative stress test 6 days earlier. How many of you have ever been in the scenario of being worried about someone's history of present illness with chest pain, and then you find out that this guy had a negative stress test recently, and you know you're going to be in for a battle? Well, if you have any questions about the reliability of that stress test, here it is. And you see there's no equivocation down there on that result. No stress-induced myocardial ischemia. This was 6 days earlier when the guy presented with some chest pain. So again, we know this is not going to be necessarily an easy case, and yet this is the kind of thing that we see all the time. I know you do as well. Here's the 12-lead EKG. Now, by the time the guy presents to the emergency department, he's pain-free. And here it is, and I'm going to give you the EKG interpretation. And actually, I take that back. This is not just the EKG interpretation. This is the confirmed cardiology interpretation that probably the next day or so, or maybe later that day. But fairly unremarkable for anything acute. This guy's got a bifascicular block, no big deal. And here's the baseline 12 lead, and so you can see that this guy has at baseline a fairly similar 12 lead EKG. It's not read as bifascicular here, but probably could be. And we'll go back to the initial 12 lead EKG when the guy initially presented. And what Jason was really worried about in this particular case was the T waves in V2, maybe just a little hint of a biphasic T wave in V3, but very clearly a biphasic T wave in lead V2, which was not present on the previous 12-lead EKG. You see nothing biphasic there, and I'll put these two EKGs against each other. Here's the baseline EKG, and here's what the patient has now. And you can see that this patient has clearly gone from nice, normal-looking T waves to biphasic in V2, and maybe just a little hint of biphasicity, if that's a word, in lead V3 as well. So anyway, and if you compare those leads, I think it becomes fairly obvious that something has changed there. So that further confirmed Jason's concern with this particular patient. He tried to admit the patient, and well, again, this is a type of reply that I've received, many of you have received before. The admitting physician is not happy about this. Says he's already been worked up. Send him home, right? Tell this guy to go back to his home. That's my picture of a home, whatever. Anyway, so send him home. He's worked up. This is probably reflux. Put him on an antacid, give him some Maalox, whatever, send him home. Well, Jason decided to not comply with that. He kept him around in the emergency department for about an hour. And what do you think happened? Well, an hour later, something changed. His chest pain came back, and so he got a 12-lead EKG an hour later. And now there's a subtle change up here. Take a look at this, really subtle, right? Well, this guy's having a big anterior wall STEMI. It's not subtle at all. And he ended up having a good outcome. He quickly went to the cath lab, 90% proximal LAD occlusion. No surprise, he had Wellens sign. And for those people that are not familiar with Wellens, we're going to spend a whole video cast next week talking about Wellens, just to clarify this. But in this week, I don't want to focus on the Wellens abnormality. We'll do that next week. This week, I want to focus a little bit on the quandary that comes up when you've got patients that have EKGs and a history of present illness that makes you concerned. What do you do? What do you do when somebody's got a concerning presentation and they've recently had a negative stress test or even an unremarkable cath? Well, how can it be that this guy's got a 90% occlusion 6 days after a negative stress test, and he rolls in for an MI? Fortunately, he ended up doing okay because Jason did not send this guy home to die. He picked up on that subtle EKG abnormality. Well, here's a couple of articles that have really highlighted why you've got to know about this this topic. And these are two articles that I recommend everybody out there needs to get and read from beginning to end. They're not long articles, but they are fantastic review articles. This is not new information, by the way. We've been talking about this almost every year at the AAM conference and also at Mel Herbert's Essentials conference and other conferences, and actually for the past 12 years now. But the reason that we're talking about it now is because it has made its way to two of the most highly regarded journals in internal medicine and cardiology. And so I'll use any excuse to talk about this because this is one of my little soapbox issues, this concept of stress testing and cath being some type of gold standard. And just to jump to the key point, all right, and I'll give you the key point, but I'm going to ask everybody out there to read these articles because they're really important if you don't know this stuff already. The key point here is great news. Size doesn't matter. Actually, it's stenosis that doesn't matter. Sorry if anyone got their hopes up, but stenosis is not all about stenosis. People have always worried about plaque size, and what we now know is that life is really all about plaque vulnerability. It's not about the plaque size that really matters. So let's talk just a little bit more about this. Okay, so stenosis is not the key. It's all about the size. Right? There's three things that determine whether a plaque is vulnerable to rupture and causing an MI. Three major factors, okay? It's the size of the fibrous cap, it's the lipid core, and it's also the composition of the lipid core, specifically the amount or percentage of inflammatory cells in the lipid core. And you'll notice that stress testing and cardiac catheterization tell you nothing about the size of a fibrous cap or lipid core or inflammatory cells, or practically nothing. They really only tell you information about how much stenosis there is. They don't tell you about what we now know is the key to plaque vulnerability. All right? So there's some problems associated with stress testing. We have recent data that shows that smaller plaques are actually oftentimes more unstable and more prone to rupture. And in contrast to what I learned in residency in med school, where people said small plaques, you don't need to worry about them. They don't rupture. They don't cause MIs. What we now know is that a lot of MIs, some studies say more than half of MIs, not all studies, but some studies say that more than half, all studies say that a large percentage of MIs are caused by non-obstructing plaques. IRA is infarct-related artery, and in many, many cases, the infarct-related artery has a non-obstructing plaque before it ruptures and produces EMI. In other words, it's not those 80 or 90% plaques that people are walking around with that cause the EMI. It's oftentimes the 30 and 40 and 50% plaques that cause a lot of the MIs. So let's take a look at a little model here, okay? So this is what we probably all learned is a concerning plaque, all right? I'll put an exclamation mark there, and I'm going to put a happy face here because that's what we were told. We're told that somebody's got an 80% size plaque that you really worry about it, and with the 50% size plaque, it's not as big a deal. This gives you this plaque down here gives you a negative stress test and a cath that's read as non-significant size occlusion. You've all seen that on a cath report before. And this is the cath that we've all been told to worry about. This gives you a positive stress test. We've all been told that these 80%, 85, 90% plaques, or at least 75% are the ones that cause all of these MIs. What we now know is that it's actually that plaque at the bottom, which is the cause of a lot of MIs, and is actually the unstable plaque. Why? It's because it's not the size of the plaque that matters. It's actually the composition of the plaque. Specifically, again, it's how thick is the fibrous cap, how much lipid is there inside the core of the plaque, and also how much inflammatory cells are there inside that plaque. So the bottom one is actually unstable. This one that gives you the negative stress test. This one that gives you those cath reports that are read as non-significant size occlusions. And instead, this plaque, which we've all been told to worry about, I'm not saying don't worry about it, but this plaque oftentimes is stable because it's got a nice, thick, fibrous cap and a relatively small lipid core. That is much less likely to rupture and cause the MI. So I'm not telling you to not worry about this, but what I am telling you is that these actually you need to worry more than you ever have before, because those cause an awful lot of the MIs. Let me give you a couple of histologic sections. This is from Journal of the American College of Cardiology from a number of years ago. Again, this is not new information. We're talking about it now only because it's brand new in the New England Journal, but it's been in the cardiology literature for a number of years. All right. Obviously, this patient didn't do well, right? Because they're doing a histologic stain of a piece of his artery. Anyway, this is a stable plaque. Take a look at how stenosed that orifice is. That you would think that's pretty concerning, right? There's a lot of stenosis in there, and in reality, this is stable. Why is it stable? It's because this patient has a very thick fibrous cap. This blue part is fibrous cap. Look how thick that is. And the lipid core, all of this white junk down here, is buried down deep, and there's not actually a whole lot of lipid core down there. This is a relatively stable plaque. So this person's probably getting positive stress tests, but this is not the kind of plaque that ruptures and causes the MI. In contrast, this is the exclamation mark. This is the plaque that causes the majority of MIs. Why? Even though it looks fairly patent, right? That's not a bad looking orifice in the lumen. What makes this unstable is actually, take a look at how thin that fibrous cap is. That's like a volcano about to blow. It's so thin, and yet there's a huge amount of lipid in here. This is a volcano about to blow. This is the type of plaque that's unstable. Again, not because of the size of the plaque, but because of how thin that fibrous cap is, and also because of how big that lipid core is. Okay, so there's problems with coronary angiography. Angiography, as I said, does not distinguish stable versus unstable, gives you no information about the fibrous cap, no information about the lipid core, also no information about the number of macrophages and inflammatory cells inside. It also doesn't give you any information about the vessel wall, and that's another important thing to be aware of. This concept called coronary artery remodeling. Interestingly, the pathologists have known about this for decades. The pathologists have known that it's not the size of the plaque or the stenosis that matters, it's the composition of the plaque that matters. But, I always say, what do they say about the pathologists? Pathologists know everything, just a day too late, right? And this has really just made its way to the general literature in more recent years, this concept of coronary artery remodeling. What that means is that as a plaque grows, if this is a vessel wall and a plaque's starting to grow, what ends up happening is that the plaque starts growing outwards, okay? It starts growing outwards in order to accommodate that growing plaque. I'll show you better images than my drawing in just a second. And in new technology like intravascular ultrasound and also old technology called autopsy, we've learned about this. So let's take a look here. What I learned about how plaques grow, and probably what you all learned about how plaques grow, is that we all learned that as plaques grow, they grow from the vessel wall into the lumen, and they start obstructing the lumen. In contrast, what we now know is that during the majority of the life of a plaque, it doesn't grow into the lumen and cause obstruction. Instead, what happens is the plaque grows outwards into the vessel wall, and it causes outward bulging or remodeling of the vessel wall. and it therefore spares a nice patent lumen. And remember, when you do an angiogram, what's the angiogram looking at? Is it looking at the vessel wall? No. Is it looking specifically at the plaque that's growing into the vessel wall? No. Angiography is looking only at the lumen, and because of this concept called remodeling, the angiogram oftentimes will be falsely negative and give you a false reassurance that there's no stenosis in the lumen, when in reality there might be a huge plaque that's growing into the vessel wall. Let's look at some more images up here. Okay, so this is a technology called intravascular ultrasound. It's a relatively newer technology over, I don't know, say the past 10 years, and it's giving cardiologists a fantastic view of how plaques actually grow. And ultrasound has come so far that they've now developed ultrasound probes that they can put on the tip of a catheter and feed it into a coronary vessel and look at the vessel from the inside out. So I'll blow this up. This is a normal coronary artery wall. This is a nice, big, thick vessel wall. And you'll notice that there's a pretty nice lumen right there, okay? This little circle right there, you can ignore that. That's just kind of a reflection of the electrode. And you see just a little smattering of atherosclerosis right there. Not a big deal. This is a pretty healthy vessel. I certainly hope my vessels look this good, all right? In contrast, and this is what essentially an intravascular ultrasound image. In contrast, this is a very diseased vessel. You see the nice thick adventitial wall right out here, and you'll notice this semicircular thing right here, that is all plaque, and it's growing outwards into the vessel wall, causing outward bulging of the vessel wall, also known as remodeling. And what ends up happening is it spares a fairly nice looking lumen. So the overall result, here's section A, 3 millimeters across, section B, 3.1 millimeters across. Huge plaque here. What does this look like on coronary angiography? Well, here's the angiogram for this vessel, all right? Here's section A, here's section B, and if you look at the angiogram, you would have no idea that right here at section B, there's actually a huge plaque growing right into that vessel wall right there, because the angiogram doesn't look at the vessel wall or the plaque. It only looks at the lumen, which is very, very nice and patent. This is read as a normal LAD. Again, this is from the cardiology. Take a look at the year, 2001. This is not new information. It's been out there in the cardiology literature for a number of years, but people have to read this stuff. Okay? Here's another one, again from the cardiology literature, 2002. Here's the angiogram. This is read as near normal LAD, and the intravascular ultrasound actually, here's the vessel lumen that the angiogram is looking at. It looks very nice and normal, right? But in reality, the intravascular ultrasound shows a huge plaque growing eccentrically into the vessel wall. So this angiogram is read as pretty, screw that up. This angiogram is read as pretty normal. And in reality, there's actually a huge plaque growing into the vessel wall. I'll show you yet one more example. This is from 2002 again. This is read as quote-unquote near normal RCA, right coronary artery. And the reason it's read as near normal right coronary artery is because the lumen looks pretty nice on the angiogram. But when you look at the angiogram, you actually have no idea that there's actually a big plaque growing right out eccentrically into the vessel wall, causing outward bulging of that wall. The wall is accommodating the plaque. The angiogram doesn't see that. All right. Very, very interesting. The other interesting thing, or unfortunate thing about angiography, is it won't tell you if there's been recent plaque rupture. Okay. So if a person ruptures a plaque and completely occludes the lumen, that's called a transmural MI. That's usually going to present as a STEMI. If a patient ruptures a plaque and only partially occludes the lumen, the patient develops symptoms and shows up, and we tend to call that unstable angina. And if you're lucky, the coronary angiogram will show you a big plaque. Your stress test might be positive. That's unstable angina, right? Let me give you a case here where we learned about this the hard way, the limitations of angiogram. A 49-year-old guy was visiting Baltimore on a business trip, came into the emergency department with chest pain, shortness of breath, diaphoresis, EKG, just non-specific junk. right? But his symptoms got better with nitroglycerin. He had a couple of risk factors, and he was such a great story. The cardiology just, after he ruled out, they took him to the cath lab, and what they found was a 40% right coronary lesion, 20% left circumflex lesion. So, with these non-significant size lesions, he was discharged with the diagnosis of reflux, right? It can't be cardiac because these lesions are too small. So he got discharged on a proton pump inhibitor. Follow up with your doctor when you return home to Arizona. Well, 2 days later, he flew back home to Arizona, and after he arrived, he was heading home. He developed some chest pain, and so instead of driving home, he went to a local emergency department where he had an inferior wall STEMI, and then he went for a cath there and was found to have a 100% right coronary artery. Remember, 2 days ago, it was 40%. How in the world do you go from 40% to 100% in 2 days? Well, let's take a look here at a 40% lesion on angiogram. This is a 40% occlusion on angiography, and most people read this as not non-significant size occlusion. But if you look at an intravascular ultrasound of somebody with unstable angina, here's your 40%, or rather your 60% patent lumen, okay? Only 40% obstructive. This lumen is 60% open, just like you're looking at here. But if you look at this intravascular ultrasound, let's see, there's the lumen. This is all vessel wall right here. This is normal, okay? All right? There is nice patent lumen. What's all this junk? That's all plaque. He's got a huge plaque sitting right outside that lumen, and so this is all plaque right up here, and you'll notice that the borders of the plaque are very jagged and irregular. Why is that? It's because the fibrous cap is gone, it's ruptured, and all you're left with is a disrupted plaque. This is your classic unstable angina. He's got a 40% size occlusion, or 60% patent lumen on angiogram. When you look at this angiogram, you have no idea that he's actually got a huge plaque right outside that area. And not only is it a big plaque, but it's already ruptured. It's unstable angina. And 2 days later, it ruptured again and clotted off the whole thing, and he ended up with a 100% occlusion right coronary artery. So when a person has a 40% occlusion, does that mean that they're stable, they're 40% occluded, and they've been 40% occluded for 5 years and they're going to be fine? Or when somebody's got a 40% occlusion, does that mean they're 40% today, and yesterday before the chest pain, they were 10% occluded? Today they're 40%, and in 2 days they're going to be 100%. You don't know, all right? Now, I'm not trying to cause a state of paranoia in amongst the listeners out there. I'm not trying to tell you that having a cath is completely meaningless or having a stress test is meaningless, but I think the key point here is to remember that we now know that risk stratifying people based on stress tests and angiography is limited. Nothing stratifies to zero. You can have a stress test 6 days ago, as Jason's case demonstrated. I've got a dozen cases of these where people had stress tests anywhere from a day ago to a week ago to a month ago to 3 months ago. And oftentimes these are patients that the physicians will say, well, they had a negative stress test, they must be okay, send them home, and it's a disaster. Or they had an unremarkable cath a couple of weeks ago or a month ago, and it's unremarkable. Nothing will risk stratify you to zero. If somebody's had a recent negative stress test, yeah, that's great. And it does lower their risk, but not to zero, okay? If somebody's had a recent cath which shows unremarkable size lesions, if there's lesions, that's not the same thing as saying they don't have coronary disease. Any lesions are concerning. And although negative size or non-remarkable lesions or very tiny lesions does risk stratify a patient to a lower concern, it doesn't risk stratify to zero. And you know what? As much as we talk about how unreliable histories can be, even the ACC and HA guidelines say that the most important thing you've got is history, history, history of present illness with these patients. So when you've got a concerning history of present illness, then you can't rely on the recent negative stress test or cath. I know this is very frustrating to hear this kind of stuff. And the bottom line is the new literature is shooting holes in what we knew faster than the new literature is filling in those holes. There are no perfect answers. I'm sorry about that. Read these articles. It's really eye-opening for people that have not heard this stuff before, and it'll shake some of your beliefs about how reliable it is when those people have had recent negative stress tests and recent negative cardiac catheterizations. Don't get mad at me either. People always get mad whenever I present this in a lecture. I don't have an answer for you. Unfortunately, the literature, as I said, is poking holes in what we know faster than the literature is filling in those holes. But the key thing is there is no perfect test, and you've got to go with your history. Take a look at those articles. They are really important articles. Share them with your cardiologist. When they're not looking, just stuff them into their lab coat pocket, stick them under their office doors. Make sure everybody who deals with acute coronary syndromes and chest pain reads these articles. They're very, very, very important. And if you learned something from this video, please share it with other people. Share it with the people you love. Anyway, I hope this was helpful. And my thanks again to Jason for sending this case. Next week, we'll talk all about Wellens. But this week, I thought we would talk about more of case discussion. Sorry this is so long. Hope it was helpful. And I will talk to you next week. Bye for now.